So today I've been tasked with discussing options for reentry. This is a very important topic because, of course, you can't treat the lesion unless you can get across the lesion. So I have no disclosures relevant to the topic today. We consider CTO as an occlusion over 3 months of duration, and these are common. We see them in up to half of our symptomatic PAD patients. The histopathology can really contribute to a lot of the challenges when crossing these lesions, and success is a really dynamic process, as we've heard today, that combines skill and strategy with understanding of your toolbox. The histology of CTOs is important in that the early tend to be more lipid-laden, recently thrombosed, softer plaques, whereas the more chronic occlusions are fibrocalcific and have neointima and channels in the adventitia that are associated with recanalization that can lead to some of the challenges with crossing CTOs. Lipid-laden intima tends to be the more early forms of chronic total occlusions, whereas fibrocalcific plaque we tend to see in these later occlusions as they age. We've seen the schematic here from Dr. Saab and his group, who characterized the cap morphology, and probably does play some role in deciding how to treat these lesions. Of course, lesion length certainly plays an important role as well. And there are various crossing strategies that one can start with, although, again, this is a very dynamic process to achieve success. And this is a patient where not uncommonly you're going to see multiple potential challenges, and your strategy is going to have to take all this into account. Chronic total occlusions include challenges of visualization, both at the proximal cap with ambiguity, as Dr. Banerjee showed in an earlier case today, as well as distal ambiguity, calcification, of course, crossing support, and some interesting implications with the new radial technology, as well as maintaining true lumen status and trying not to extend dissection. And of course, lesion extension and inability to reenter probably is the biggest challenge when we encounter chronic total occlusions, although dissection, perforation, embolization, and creation of AV fistulae can be an important risk as well to consider. When I think about reentry tools, though, I do think of cost, both on a money-wise standpoint as well as the adverse events associated with these tools, and consider the effectiveness. And of course, wire escalation, we tend not to use these, tend to be more for coronary cases where the occlusions are shorter. We generally use wire and catheter, which is a fairly effective approach in many cases, although CTO crossing devices also are helpful and many times necessary. This is a really seminal paper recounting 10 years of experience from 11 U.S. centers and over 1,300 patients that Dr. Banerjee and his group, leaders in this field, have put together, many of which are on this panel today, looking at the comparative effectiveness, essentially, of crossing strategy. And what the authors found is that over 80% started with a wire catheter approach, and we found that technical success was a bit lower with that strategy compared to starting with a CTO crossing device. However, there was no difference in procedural success. The duration, fluoro time, and contrast volume were essentially not different between the two strategies. However, late TLR and major amputation did tend to be worse and higher at 12 months with the wire catheter approach from the start. So in general, the wire catheter approach, as I've shown earlier, is perhaps a more cost-effective strategy in the lab, but maybe not when considered long-term. And certainly we want to avoid late revascularization, of course, in major amputation. So what I took from the XLPAD registry is there are higher procedural costs with these devices, although perhaps improved success, and then they deserve a thought. And these devices may be associated with lower TLR and amputation rates at a year. So we're going to just talk about kind of qualitatively some of the different techniques we can use to cross these lesions. And of course, the knuckled wire approach and antegrade dissection reentry is probably one of the more common forms. And you want to get your catheter right on the proximal cap. This works great for short occlusions that have that concave proximal cap when you essentially just power through the occlusion. But sometimes you encounter calcium that can lead to collaterals, and ambiguous distal reentry can limit efficacy. And so parallel technique and wire escalation can really help to facilitate crossing. However, more often I find that controlled antegrade and retrograde subintimal tracking or CART can be helpful, and frankly reverse CART, but we'll go through cart, which is both wires from antegrade and retrograde are in your subintimal space. You're having trouble meeting the two, so you inflate a balloon retrograde, and that allows for a microchannel to develop, and you can redirect your wire and cross the lesion. Reverse cart is just the opposite of that, where you inflate from the other direction, but facilitates the same wire crossing, and Dr. Shishebor showed a case of parallel balloon, another way to basically fenestrate the occlusion and allow for passage of the wire. This is by no means an exhaustive table of the crossing systems that are available. There are many, many more, but just wanted to give a representation where you have blunt microdissection tools like a front runner, which does not use a wire and just basically bores through the plaque. You have the crosser, which uses sonic energy to penetrate the cap. There are new devices like the Wingman, which uses a needle that punctures the cap and allows for crossing. You have various mother and daughter catheter systems to power through occlusions, and of course the directional or orbital atherectomy devices to basically screw into the cap and allow for passage. Once you get into that subintimal space, you many times are forced to re-enter, so that not always is possible just with a wire approach, so we need catheters to help do that, and there are various tools we have to help with that. The Outback device, of course, is probably the most well-known one, although my preference is the Pioneer catheter because of the ultrasound guidance. The interior and Vion system is used, as well as the off-road system. The consideration here is the Pioneer device is about $3,000. The Outback device is somewhere around $2,000. These add significant cost to the procedure. Crossing occluded stents is particularly challenging. The proximal cap tends to be densely fibrotic and may limit the antegrade approach, so retrograde crossing may in fact be a bit easier. The laser atherectomy systems can be used in a step technique without a wire to puncture the heavily fibrotic cap and get into the stent, and then direct stent puncture is another option. And this essentially is retrograde crossing using direct access through the side struts of an occluded stent. It can be performed using the Cook needle and an 035 wire, although various techniques have been described. Essentially, the retrograde wire is knuckled through. You can many times you do need to sheath to provide support to get through the proximal cap, and if it's got a downside, it's probably the limited ability to control bleeding if you create a big hole in the stent and you're unable to cross. So my preferred approach in considering this the schematic is actually retrograde crossing, and I think there are more numerous options we've heard a lot about at this meeting, and specifically pedal access, which is commonly available, safe, efficient, and quite effective. And the advantage is I think it helps to simplify the procedure in some way because you shorten the length of your occlusion by great visualization through retrograde injection, in addition to your proximal antegrade arteriography. It allows for distal cap crossing, which in some cases can be quite easy compared to the proximal cap. Wire externalization offers great rail support, so essentially you can power through many of these lesions and you maintain proximal and distal true lumen without extending the dissection, and there's tremendous flexibility with this approach. It does require thinking ahead. You know, the popliteal and proximal tibial axis also has been presented at this meeting, although perhaps there are some risks in positioning of the patient that are downsides to the approach, but certainly effective when they're needed. I find that just using a wire and microcatheter from the pedal approach is often all I need to help pass the wire and externalize to floss. You have to think about this from the case start, though. You have to know you're likely dealing with a chronic total occlusion. Sometimes we don't know that right from the start, but certainly preparing the foot and planning the case for possible pedal access is helpful, in my opinion. A high-frequency ultrasound probe in your lab is really the key to success in pedal access, and if you don't have high-quality ultrasound, I'd encourage your health system and cath lab to consider that. Micropuncture needle and wire kits can be helpful, although I find just the 014, 018 wire systems we routinely are used to using can be quite helpful here with a short micropuncture needle. Of course, there are some considerations for anticoagulation and sheath maintenance, vasodilators, and hemostasis once you do get in. Other considerations for chronic total occlusions, we've heard at this meeting about autologous, autologous vein graft and femoral popliteal bypass is an important treatment option we shouldn't forget about. Extravascular ultrasound facilitated crossing has been described by some of the panel members here, as well as Mustafa and colleagues. This requires a committed sonographer, but definitely is a safe and effective approach in helping to guide crossing of these difficult lesions. And then transvenous IVUS-directed CTO crossing has been used successfully in Japan, and a lot of imaging guidance may be, in fact, quite helpful in crossing these complex lesions. And then finally, just a plug to use a hybrid approach when deciding how best to treat these lesions. If you have imaging ahead of time, to talk to surgical colleagues and endovascular specialists to help plan an approach that makes sense for that patient. So in conclusion, you're going to encounter chronic total occlusions. They do add procedural time and cost. Pedal axis and retrograde crossing are safe and effective and give you a lot of flexibility in these complex procedures, and an adaptive algorithmic approach improves efficiency and maximizes success. Thank you.
Thank you.